So let's talk about parathyroid. Parathyroid. So we have hyperparathyroidism. The most common cause of hypercalcemia is asymptomatic hyperparathyroidism. So these are people that have the parathyroid producing PTH, but they're not becoming symptomatic. It's kind of like a incidental finding when we just do a blood test. They have high levels of calcium. Okay? The most common symptomatic hypercalcemia is cancer. All right? It starts eating away at bone. Metastatic bone cancer. It's going to put calcium into the bloodstream. So yes, one of the things that we're concerned about when we have somebody who's not symptomatic, we want to make sure that they don't have early signs of bone cancer. Okay? If they find that they have bone cancer, remember the most common cause of bone cancer is metastatic. So it's coming from some other place. Gets scary, okay? Another cause of hypercalcemia is that sometimes certain cancers, like lung cancer, actually is going to secrete a PTH-like hormone. So that's the other thing. Chest X-ray is going to be done with people with unknown cause of hypercalcemia. They want to make sure that there's nothing wrong with the lungs, right? That's why they're doing all this, okay? So if you increase PTH, you're going to increase calcium in the blood. You will have hypercalcemia. That kind of makes sense, okay? You'll get brittle bones because the osteoclasts were going to chomp away at the bone and put calcium into the bloodstream. So you get osteoporosis, right? You get duodenal ulcers. We realize that if you put too much calcium in the person's stomach, that actually can cause ulcers to occur. You get kidney stones because the kidney just gets overwhelmed with all this calcium, and it can't. You're giving us too much calcium for it to actually be converted and put it into urine, so they start forming stones. And we know that calcium is important in order to do nerve conduction, like in the brain. But if you have too much of it, it can start messing up things in the brain and cause psychosis. So my little mnemonic on this, I think I told you before, is bones, moans, stones, and groans, right? So bones and moans, and then you got kidney stones and groans, that kind of thing, right? All right, so that's usually good. Those are nice mnemonics when you get to hypercalcemia. So this is the hyperparathyroidism, and you can see where it actually hits all these different things. So you can do that on your own. This is also another one I got from the book too, where you can actually see where all the signs and symptoms are in picture form. But really, if you understand what PTH does, you don't have to even look at these because it kind of makes sense. Okay? So we have different types of hyperparathyroidism. We have primary hyperparathyroidism. The parathyroidism is very common. About 1 in 400 people have this. This is where the parathyroid is going to secrete an obnoxious amount of PTH. Why, we're not too sure. But the most common case that we see here are postmenopausal women who have this adenoma there. About 90% of cases are in this. We also have secondary hyperparathyroidism, and it's due to, well, a decrease of calcium, which tells the parathyroid to release, to make more cells in itself, hyperplasia, and that will make more PTH, which will increase the calcium in the blood. So what's going to happen here, the most common cause is increase of phosphate. So where does this come in? Okay. It's in my first few slides of this PowerPoint presentation I had you guys review. But what happens here is that the PTH is going to go to the kidney, all right, and it's going to normally, not on here, I'm just saying normally what PTH does, PTH is going to bring in or reabsorb calcium into the bloodstream. So PTH will go to the bone because it's going to go to osteoclast activity, get calcium into blood. It'll go to the intestines so that we can actually absorb the calcium from your diet. And it's going to go to the kidney. And what does it do in the kidney? It's going to reabsorb calcium. Now, this is where phosphate and calcium come in. Calcium, as calcium gets reabsorbed, phosphate has to be excreted. They actually exchange with each other. Okay, does that make sense? They do the opposites. So in a case of someone who's got increased phosphates in the blood, well, the kidney is then going to try and spill out phosphates in the urine, but in the process of doing that, calcium will go back into the bloodstream. So when you have high levels of phosphate, it's going to cause high levels of calcium because it's trying to fix its phosphate. Does that make sense? Okay? So that's what's happening with that. All right, hypoparathyroidism. Most common cause of this? Accidental, we use the word iatrogenic, I think is the proper word. Removal of the parathyroids in the process of trying to remove the thyroid. If the thyroid has cancer, and it's a pretty nasty cancer, and it starts going all around the parathyroids, it's difficult to salvage the parathyroids because it's encased in all this cancer. So they remove the thyroid, and in the process, they're also removing the parathyroids. And that is what's causing, so it's not unlikely someone has a thyroidectomy, they remove the thyroid, and a few weeks later, their calcium levels are very low because there's no PTH that's coming out. Okay? So you get this hypocalcemia, and because calcium is important for nerves, the stimulation and muscle contraction, it kind of reaches out. It tries to become a little bit more excitable because it needs that calcium to come in, but there's not any calcium there. So you start getting these twitches and convulsions and